Extract 1, questions 1 to 12. You hear a physician talking to a new patient called Mrs. Delilah. For questions 1 to 12, complete the following notes with a word or short phrase. You now have 30 seconds to look at the notes. Hello, doctor. Good morning.
Good morning. Tell me, what seems to be the problem?
Doctor, I am a patient of I-131-induced hypothyroidism for the past 6 years and have gained weight and edema over the last 3 weeks.
Your age?
57 years. I also have other complications like fibromyalgia, Crohn's disease, inflammatory bowel disease, COPD, and disc disease, as well as the thyroid disorder. Also, my abdominal girth is increasing. Plus, I have increased edema in my legs, doctor.
Oh, I see. What medications were you taking?
I was on Norvasc and lisinopril for years for hypertension. I also take Synthroid and thyroid hormone.
Do you smoke or drink?
No, doctor. I had a hysterectomy and a cholecystectomy surgery 2 years back, doctor.
It seems you're allergic to IV dye, sulfa, NSAIDs, compazine, and Demerol.
Yes, doctor.
Do any of your close family members have thyroid disease?
Yeah, my sister has Hashimoto thyroiditis and Graves' disease.
It seems you've gained 20 pounds of weight during the past few weeks.
Yes, I experience frequent sweats and fatigue as well.
Do you feel any chest pain?
No, doctor.
What about your bowel movements?
It is loosened, doctor.
Do you have abdominal pain?
No, doctor.
Your blood pressure shows 140/70, and your heart rate is 84 and a febrile. You are clinically and biochemically euthyroid. Your TSH is mildly suppressed, but your free T4 is normal, and with your weight gain, I am not going to decrease the dose of levothyroxine. I will continue you on 300 micrograms of Synthroid daily. If you want to lose your weight, then repeat the thyroid function test in 6 weeks' time to ensure that you are hyperthyroid.
Okay, doctor.
I need to explain to you a few things about edema. For the optimal functioning of our body, the water content should be about 70%. This takes care of regulating our water balance. Our kidneys regulate the water level of our body with the help of the antidiuretic hormone called vasopressin. The pituitary gland secretes the vasopressin to prevent excessive water loss from our kidneys, to hold on the water level to ensure optimal functioning of our body and prevent dehydration. More or less, edema is a symptom of a malfunctioning of water regulation process of our body. Once our body has an adequate water level, and when our kidney excretes water, vasopressin should turn off. However, in the case of edema, vasopressin mechanism malfunctions and our body continues to retain excess water.
Other than medications, what can I do to control edema, doctor?
There are certain simple dietary and lifestyle choices I would suggest for you which can promote healthy elimination of excess water. One of the most prominent things you can do is to maximize your water intake through drink and food. Excessive intake of water promotes regular production and expulsion of urine called diuresis.
What are all the foods I should eat, doctor?
Foods such as celery, grapes, melons, spinach, carrots, and other green leafy vegetables. Similarly, try to reduce the sodium intake in your diet. High sodium always leads to excess retention of water. Beware of canned and processed foods, which are often high in sodium. Foods such as white bread, refined foods, refined sugars, pasta, and even alcohol can result in water retention. Exercise of any kind that increases heart rate is very helpful in promoting the fluid movement from the extremities to the heart, therefore reducing edema in the extremities.
Thank you very much, doctor.
Extract 2, questions 13 to 24. You hear a physician talking to a patient called Mrs. Gonzalez. For questions 13 to 24, complete the following notes with a word or short phrase. You now have 30 seconds to look at the notes.
Hello, doctor. Good morning.
Good morning. May I know your problem?
Well, when I was walking into a store yesterday, I felt dizzy and had some cold sweats, some shortness of breath, but there was no chest pain, nausea, or vomiting. I suddenly sat down and lost consciousness for a minute or so. However, there wasn't any tonic-clonic movements.
What's your age?
48.
Did you had any cyanosis, which means that the skin goes bluish?
No, doctor. Then I got up on my own, and even now I'm having mild shortness of breath upon exertion. This is totally unusual for me, doctor.
Do you have any fever or syncopal episodes?
No, doctor.
Have you had any diseases or surgery in the past?
Well, a year ago, pulmonary embolism was diagnosed. But during that time, I had an IVC filter placed due to massive gastrointestinal bleeding diverticulosis and gastric ulcers, paroxysmal atrial fibrillation, and no anticoagulation due to history of gastrointestinal bleed. Coronary artery disease status was post-bypass graft surgery at that time. I had to stay in the ICU for 3 weeks due to lower GI bleed again.
Okay. What medications are you taking now?
Aspirin, potassium, Lasix, levothyroxine, lisinopril, Pacerone, Protonix, Toprol, vitamin B, Zetia, Zyrtec.
Are you allergic to any medicines?
Yes, to sulfa.
Well, your blood pressure is 155/57. Pulse rate is 61. Respiration's 18, and oxygen saturation is 95% on room air. No lymph nodes or masses. No lower extremity edema. No redness or hotness. The laboratory reports show creatine 2.1 and hemoglobin 9.6. Your chest x-ray is clear. You have developed pulmonary embolism with contraindication to anticoagulation due to recurrent gastrointestinal bleed. Status post IVC filter. You have also developed mitral valve disease, coronary artery disease, and peripheral vascular disease per cardiology. No evidence of chronic thromboembolic disease per VQ scan. We cannot rule out pulmonary hypertension. Shortness of breath upon exertion. You will need a pulmonary function test as an outpatient. I will do oxygen saturation with ambulation to prevent it causing loss of consciousness.
That is the end of Part A. Now look at Part B. Part B. In this part of the test, you will hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare environment. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You will have time to read each question before you listen to the audio. Complete the answers as you listen to the audio. Now look at the question 25. You hear a monologue by a physician explaining to his staff about cutaneous manifestations. Now read the question. Cutaneous manifestations are the medical consequences of starvation, vomiting, abuse of drugs such as diuretics and laxatives, and of psychiatric morbidity. These manifestations include lanugo-like body hair, cirrhosis, carotenoderma, telogen effluvium, acne, seborrheic dermatitis, hyperpigmentation, acrocyanosis, petrichae, pernosis, livido reticularis, interdigital intertrigo, paronychia, generalized pruritus, acquired scurae distente, slower wound healing, prurigo pigmentosa, edema, linear erythema chronique, acral coldness, pellagra, scurvy, and acrodermatitis enteropathica. The most characteristic cutaneous sign of vomiting is knuckle calluses called Russell's sign. Symptoms arising from laxative or diuretic abuse include adverse reactions to drugs. Symptoms arising from psychiatric morbidity include the consequences of self-induced trauma. Question 26. You hear a monologue by a physician explaining to his staff about symptoms of anorexia nervosa. Now read the question. Multiple studies of anorexia nervosa patients have revealed a decreased left ventricular mass, cardiac output, left ventricular index, and left ventricular diastolic and systolic dimensions. Long-standing hypovolemia has also been seen in the patients. Mitral valve motion abnormalities, including mitral valve prolapse, were also seen in a distinct minority that can cause chest pain and palpitations, but the ejection fraction seems to remain preserved in most patients. However, weight restoration had a significant impact in normalization of cardiac dimensions. Question 27. You hear a discussion between a physician and his nurse about endometriosis. Now read the question. Hello, doctor. What is endometriosis? Well, endometriosis is a disorder when the tissue that forms the lining of uterus grows outside of the uterine cavity. It is abnormal for endometrial tissue to spread beyond the pelvic region. This condition is known as an endometrial implant. The hormonal changes of the menstrual cycle impact the displaced endometrial tissue, causing the region to become painful, inflamed, and making the tissue grow thicker and finally break down. At one stage, the broken tissue has nowhere to go and becomes trapped in the pelvis. Question 28. You hear a discussion between the physician and his nurse about treating the signs of eating disorders. Now read the question. Hello, doctor. What kinds of treatment measures do you suggest for the signs caused due to eating disorders? Although skin signs of the patients with eating disorders improve as they gain weight, the dermatologist is responsible to treat the dermatological conditions as well. Antibacterials or azelaic acid is effective to treat acne that these may be described as monotherapy or in combinations. Combination zinc with antibacterials such as erythromycin are also suggested because zinc deficiency can be a possible cause for this sign. Angular stomatitis, cheilitis, and nail fragility can be treated with topical tocopherol. Cirrhosis improves with moisturizing ointments. Ointments that contain urea are effective in decreasing the size of Russell's sign. Question 29. You hear a discussion between a physician and his junior about pain transmission. Now read the question. Hello, doctor. What is the theory of pain transmission? Well, the nerve fibers that are connected to the receptors in the skin, muscles, and organs called primary afferent axons transmits the pain signals to the brain and spinal cord. These axons of various sizes may be myelinated or unmyelinated that are classified into different groups based on their size, namely A alpha, A beta, A delta, and C nerve fibers. All of the A afferent axons fibers are myelinated, while C afferent axons fibers are unmyelinated. The thickness of a fiber determines the speedy transmission of information. According to the gate control theory of pain, the pain is a function to balance between the information traveling into the spinal cord through large and small nerve fibers. Small nerve fibers transmit nociceptive information of the pain, whereas large nerve fibers carry nociceptive information. The large and small axon nerve fibers synapse on projection neuron cells to the brain and on inhibitory interneurons within the dorsal horn of the spinal cord. The firing of the projection neuron signals pain to the brain. The inhibitory interneuron decreases the chances of the firing of the projection neuron. Question 30. You hear a discussion between a physician and his nurse about subclinical seizures. Now read the question. Hello, doctor. When do subclinical seizures occur? Well, subclinical seizures occur due to unusual electrical activity within the brain. Often, the symptoms are unnoticed, even by the patient. The only method to detect subclinical seizures is performing an electroencephalogram to measure the electrical activity of the brain. That can capture the seizure activity. At times, subclinical seizures are mistaken for the abnormal behavior of autistic patients. For instance, an autistic student showed good cognitive development in his studies last year. However, this year his progress has slowed down. Signs such as aggression or meltdowns were seen in the patient. He used to daydream and ignore others when anyone asked him anything. This condition was mistaken by his parents for autism. All such signs are often mistaken for behavioral issues linked with autism that can actually be connected with a subclinical seizure. According to findings, subclinical seizures may be the cause of psychiatric disorders or compulsive and behavioral disorders or even schizophrenic, criminal, and antisocial activities. That is the end of Part B. Now look at Part C. Part C. In this part of the test, you'll hear two different extracts. In each extract, you'll hear health professionals talking about specific aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete the answers as you listen to the audio. Now look at Extract 1. Extract 1. Questions 31 to 36. You hear the doctor briefing his staff about guidelines for the early detection of cancer. You have 90 seconds to read questions 31 to 36. Guidelines for the early detection of cancer. I am going to explain to you the guidelines for screening different types of cancers. These screening tests are suggested to detect cancer before the patient develops any symptoms. Colon and rectal cancer and polyps. Starting regular screening at the age of 45 is suggested for people at average risk of colorectal cancer. The screening can be performed either with a sensitive test that examines for cancer signs in the stool of the person or with an exam to look at the colon and rectum. This can be done either with a sensitive test that looks for signs of cancer in a person's stool or with an exam that looks at the colon and rectum. If the person is maintaining a good health, he should continue with regular screening through to the age of 75. For people aged 76 to 85, they should confirm with the physician whether continuing with the screening is right or not. People above 85 should no longer get colorectal cancer screenings. If the person wishes to be screened with a test other than a colonoscopy, any abnormal result should be followed up with a colonoscopy. Cervical cancer. Cervical cancer screening should begin at age 21. However, women below 21 years should not be screened. Women between 21 to 29 should have a Pap screening done once in every 3 years. However, HPV screening should not be performed for this age group unless it is required after an abnormal Pap test result. Women between 30 to 65 should have a Pap test in addition to HPV test termed as co-testing done every 5 years. This is the most suggested approach. However, having a Pap test alone is also okay for this age group. Women above 65 who have had regular cervical cancer screening for the past 10 years with normal results should not be tested for cervical cancer. Once screening is discontinued, it should not be started again. Women with a history of severe cervical precancer should continue screening for at least 20 years after that diagnosis, even if testing goes past age 65. The women whose uterus and cervix have been removed, total hysterectomy, for reasons not related to cervical cancer and without any cervical cancer history or severe precancer should not be screened. Women vaccinated against HPV should still follow the screening recommendations for their age groups. Women with a history of HIV infection, organ transplant, DES exposure, etc. may require a different screening schedule for cervical cancer. Breast cancer. Women from 40 to 44 should have the choice to start annual breast cancer screening with mammograms. Women from 45 to 54 should get yearly mammograms. Women above 55 may get mammograms once in every 2 years. Screening should continue as long as a woman is in good health and is expected to live more than 10 years. Women should be well informed with the known benefits, potential harms, and limitations linked to breast cancer screening. Certain women with a genetic tendency, family history, or certain other factors should get screened with MRIs along with mammograms. Endometrial cancer. I would recommend that during menopause, every woman should be informed about the risks and symptoms of endometrial cancer. Certain women with a disease history may need to opt for a yearly endometrial biopsy. Lung cancer. I would recommend yearly lung cancer screening with a low-dose CT scan for certain people prone to lung cancer who meet the following criteria. Aged between 55 to 74 years and maintaining good health. And stopped smoking in the past 15 years. And having a minimum of 30 packs per year smoking history. Prostate cancer. I would recommend that men make an informed decision after consulting with a physician whether to be screened for prostate cancer. Research has not yet proven that the benefits of screening outweigh the harms of testing and treatment. Therefore, I believe that men should not be screened without understanding about the risk factors and benefits of screening and treatment. Starting from the age of 50, men should consult a physician about the risk factors and benefits of screening so that they can decide if screening is right for them or not. If they are African American or have a father or brother who had prostate cancer before the age of 65, one should consult a physician right from the age of 45. If one decides to be screened, he should get a prostate-specific antigen blood test with or without a rectal exam. How often he will be tested will depend on his prostate-specific antigen level.
Now look at Extract 2. Extract 2, questions 37 to 42. You hear a speech pathologist, Kevin Drews, giving a presentation to a group of trainees. You now have 90 seconds to read questions 37 to 42.
First of all, thank you for having me here today. I'm going to be talking about a topic that those of you who choose to go into pediatrics will encounter regularly, and it is important to know how to help parents, as well as to know when to refer children to a specialist. The topic is Late Language Emergence, or LLE. LLE refers to a delay in language onset, with no other diagnosed disabilities or developmental delays, and is diagnosed when the trajectories of language development are below age expectations. Children who present with LLE or late talkers may present with expressive language delays or mixed expressive and receptive delays. Expressive language delays refer to delayed vocabulary acquisition and typically involve slow development of sentence structure and articulation. Late talkers with mixed expressive and receptive language delays exhibit delays comprehending language and in oral language production. Some children with LLE are often referred to as late bloomers, indicating that they will catch up with their peers by 3 to 5 years of age. And in fact, approximately 50 to 70% of late talkers are reported to catch up to peers and demonstrate normal language development by late preschool and school age, with only 1 in 5 late talkers still demonstrating language impairment at the age of 7. However, it can be difficult to differentiate between late bloomers and late talkers, as it will only become apparent later if the child will continue to have delays or catch up with peers. And as we will discuss in a moment, early intervention can be key. Risk factors for LLE can be divided into a number of categories, including child factors, family factors, and protective factors. Child factors include gender and motor development. For example, boys are at a higher risk for LLE than girls. Family factors include family history as well as the presence of siblings. Children who have parents with a history of LLE are more likely to experience this problem as well as children who have more siblings. This may be due to the fact that single children typically receive more attention from their parents. Protective factors refer to areas such as pre, peri, and postnatal care, as well as learning opportunities available to the child. Learning opportunities that are beneficial to all children but particularly those with LLE, include exposure to rich and varied vocabulary, syntax, and discourse patterns, access to printed materials, involvement in structure and unstructured play interactions and conversations, and engagement in gross and fine motor activities, among others. Protective factors are particularly important as early identification and intervention can mitigate the impact of other risk factors. LLE can also be an early or secondary sign of other disorders, such as specific language impairment, social communication disorder, autism spectrum disorder, among others. Making a differential diagnosis requires close monitoring of the global development of the child in other domains, such as cognitive, communication, sensory, and motor skills. Initial treatment for toddlers and preschoolers with LLE typically involves a speech-language pathologist monitoring the progress of the child and introducing indirect language stimulation, which can help remediate problems and prevent future difficulties and the need for subsequent school-based services. When language delays persist over time, or are present with other identified or suspected delays or disabilities, such as those previously mentioned, direct speech and language services are necessary. The speech-language pathologist will take into consideration a number of factors when developing an intervention plan, such as language or languages spoken at home, cultural background, and family history. A key component of success of intervention with children with LLE is working closely with the families. Families must be given the opportunity to share concerns and priorities that may influence the intervention plan. This will help to ensure a supportive, informed, and collaborative relationship with the family, which is most definitely in the child's best interest. Most intervention plans will take a multidisciplinary approach in which the speech-language pathologist will work with the family and a variety of other professionals, such as audiologists, special education teachers, interpreters, neurodevelopmental pediatricians, occupational therapists, school psychologists, among other health professionals.
That is the end of Part C. You now have 2 minutes to check your answers.